So this way we will have ministry that will be to the whole family, and even we're going to talk about ministry to nurses and to staff, how we include them all. The first scenario we did on the code blue, we gave that as the patient surviving, okay? This one we're going to give to the patient expiring, passing away, dying, okay? Most code blues survive. Most of the time, they're doing their job the same way every time, but most of the time they catch it quick enough, the patient survives. So they're with us, and we're talking about caring for the family with a patient may be very sickly, or they may be almost fine, but some kind of heart issue, lung issue. But this scenario, we're going to give the scenario of the patient who expired. We'll talk a little later about our ministry we're going to be doing with Paul and others for the chaplaincy committee. If you're interested in leadership, get with Paul, and he will be getting with some of you that he has pegged as prominent leaders. And we will be coming back for probably a 2-hour session to just do a seminar on how to get our policies in order, how to orchestrate some things we need to do to make this chaplaincy work. So many times we just kind of started it, and what I hear as I go to different hospitals, yeah, we did that 5 years ago, but I don't know what happened to them. I mean, I don't know where they are. In fact, I went to one hospital, and the administration told me, we don't have any volunteer chaplains anymore. I go, okay, well, we'll start from scratch and get some. So we had our training, basic training meeting, and I saw a man come in with a very old, tattered volunteer chaplain badge. And I go, hi, how you doing? It's see that you're a volunteer chaplain. Yeah, I've been one for 7 years. Actively? Oh, yeah, I come in here every week. I said, how many others are there? He goes, what, 7 or 8 of us? I go, but they didn't know them. But they were coming in doing their thing, and maybe a few nurses knew they were, but administration had no clue they had volunteer chaplains. So that's where we need, we're not talking, we're not communicating, okay?
They know us.
Yeah, so we need to get this team to where they know you and you know them, and then we're training the whole team. And I'll be back later, and I'll actually do some training with nursing, what spiritual care is and those kind of things. So today, let's look into what we do with the patient removal of life support. This patient on life support is going to be in your ICU. I don't think your hospital does open heart surgery or open lung surgery, do they? Do you have a critical care recovery unit?
Yeah.
You have a critical care unit? Not just an ICU, but critical care?
No, I don't think so.
Okay. Hospitals that do...
I know we're on the verge. I'm trying to
Okay.
think whether they get into that. I don't think so.
Hospitals that do open heart, open lung, or brain
No,
surgery
yeah.
have a critical care unit.
No.
So they do life support too. Now I know in the ER they place patients on life support in the ER, but they don't treat them there. Soon they send them off to the ICU, okay?
Mm-hmm.
So when they're going to be removed from life support in your hospital, they're going to be in an ICU. Other floors do not do life support. They do not, those nurses don't do ventilators. They don't do the heavy-duty drugs to keep the heart stabilized or lung stabilized. They don't do dialysis and things like that. But they will do treatment of the care and kind of med-surg and surgery stuff like that. But this is a different kind of a care where the patient, and I'm going to call it life support, and I'm really going to maybe rephrase that as life sustaining. And we'll talk about in a minute how when patients are taken off life support, they don't necessarily die that minute. And patients are like, oh, what happened? I thought they were in life support. Okay, let's call it life sustaining, or keeping them comfortable where you're helping the heartbeat or helping the lungs or helping the kidneys or whatever so they can then repair. So we'll understand that this is the place where that kind of care will be done. Let's talk about certain kinds of life support. Be the ventilator, that machine that breathes for them. There will be a seminar that I'll be doing. I'll be coming back annually to do annual education. One seminar will be just on technology and terminology that you're going to hear in the hospital. So we'll show you a defibrillator. We'll show you a ventilator. We'll show you the ambu bag where they breathe. We'll show you the different kind of PICC lines. So you go, oh, okay. But just to be simple in this, there are some things that are life support. This is the ventilator. life-sustaining medications that you won't get in any other floor of the hospital, but in this area they may be pushing certain kind of drugs that are special for life-sustaining. And then the internal defibrillator. You notice people with the pacemaker, right? You know, some of those pacemakers have defibrillators on them. They do different things. The pacemaker just keeps pace, but it doesn't keep you alive, but it keeps the pace. But the defibrillator, when your heart stops, it fires. It does its job. So the day that we're going to take a patient off life support, we have to turn this defibrillator off. So that means whoever made that defibrillator, whatever pharmaceutical company made that tech comes in, and just like the first day when they took a laptop and a probe over the defibrillator and set it, they will come back again and turn it off. Because if they turn the machines off that are keeping that patient alive and that heart stops, that thing's on fire. So this kind of just protocol for the nurses, okay, does this case, do we do this? And yes, you can place a big heavy magnet over that, and they keep one in ICU just in case they need one. But just in case that rep can't come in there and turn that off, but that doesn't always work perfectly. The best way, they call ahead of time, they come in, they turn that off, then you remove the medications and the defibrillator and the ventilator. There are other kind of treatments if not many hospitals do this, but this is kind of dialysis that is 24 hours a day, 7 days a week. So this CRRT or DBVHD is that kind of life-sustaining dialysis. It isn't the thing that you get for a couple hours every other day. It is continuous cleaning of the blood system dialysis that keeps them alive. That needs to be turned off. And then maybe what we talked about, nutrition and hydration. And that is very rarely brought up and discussed. Do you want to continue this nutrition hydration? We're going to be taking the patient off of life support at 4 o'clock today. At 4 o'clock, when we take off all these drugs and all this medication, all these machines, do you want us to still feed them or not? Well, is it going to make much difference? It might prolong things, but they're not going to get better. Well, then don't do it. Or, yes, just do it. So it's either way. It may be a choice the family has of giving nutrition and hydration, but that last advanced directive may decide that for you, where they said yes or no. And yes, when they were 35 years old and they wrote it out, they may go, yes, sure, feed me, and they said yes. So then when yes, we're going to, because they misunderstood when this was going to happen and why. Organ and tissue donation. Remember we talked about Joint Commission is that agency that comes in and inspects hospitals, inspects your fire extinguishers, your cleanliness, your medicines are in date and all that. They oversee all the hospitals, and they noted that in 2008 they said there are 92,000 patients waiting for an organ or tissue, that if they had that organ tissue they would live. And now it's really 108,000, maybe even more than that now. That means these sickly patients out there have a pager, and they're waiting for that pager to go off, which tells them to come to their hospital because there is an organ or tissue that's going to be transplanted and they're going to live. 108,000 patients are waiting for that. So Joint Commission said that's way too many patients waiting for organs and tissues, and they said to the organ procurement agencies, your rulings, your strictness is too tough. See, the strictness was, before 2008, that the patients that were going to receive live organs had to be brain dead. Not receive them, they were going to donate them, had to be brain dead. Now that's brain stem and total brain, no wavelength, so that there's not too many of those. I told you how rare that was. So even, there's the motorcycle victim out there that had brain injury, head injury, the rest of the body's good, able to donate those organs to science. Well, there's not too many of those total brain deaths. So that meant there were a lot of good organs going to the grave that could have been given to someone else, but they couldn't because that was the ruling, total brain death. So they said, let's change that to cardiac death, meaning the patient's going to die anyway by a cardiac problem. The heart is so sickly it can't sustain itself, so that when the patient dies, when we remove them from life support, we rush the body to the OR, remove the organs that are necessary, and get those to the patients that need them. That was a whole huge, and that was just 2008.
So now they are dead.
They're dead.
They're dead.
We removed life support. They were going to die anyway. Okay, they weren't going to exist without that. They already said at 4 o'clock we're going to remove life support. Oh, but they're an organ donor, so let's keep them alive for a moment of time to bring the organ procurement agency nurse in to look at tissue type and blood type to see if they could donate. Maybe they can't donate, so why would we take anything? And then just look on our roster in our state. Is there someone that, let's say they have a good heart, but bad kidneys, but they have a good heart, and we have someone in our state that needs that heart valve or whole heart. But if they didn't need it, they wouldn't take it, okay? But if they had someone, same blood type, same tissue type, and this patient donating didn't have any known illness that would prevent them from donating, then let's keep this patient on life support until we've got this whole setup that someone out there needs that. And that may take hours or a day or so. So this all is in place, that there's someone out there that needs this. And so then, okay, we've got that in place, and now we take life support off the patient who's going to die anyway, and then remove those organs, and then rush those organs to the hospital where the patient is and needs that. Sometimes those organs need to get there in an hour or 2 hours, or whatever the time limit is. Yes, sir.
I'm confused about this.
Okay.
So,
Let's
you
slow
don't
down.
have to- so with my mom, she
Yeah.
had those she had the test for her brain was flat.
Okay.
So then we kept her on the ventilator, the family came in for two more days.
Okay.
So, you're telling me now that if she was an organ donor, because of the flat brain, they could take it, but now they don't have to do that? You just have to, like, have be in cardiac arrest and not be brain dead?
Not just cardiac arrest,
I mean,
a diseased
or
heart
ventilator,
that can never get better.
They never get better.
And they're going to take them off life support anyway.
Take my life support anyway.
And so we wait and be sure we've got the organ donation set up, and then we take them off life support.
But then they die.
And then they die,
And then they
as they
die.
would anyway.
As they would anyway, okay, but they don't have to.
It wouldn't,
That's a
they don't
brain dead.
cause death. They just take them off life support as we would anyway.
As they would anyway.
Is that clear with everybody?
And then they're pronounced dead,
They're pronounced dead.
and then they die. Then the body goes.
The body doesn't go anywhere. They remove the organs right there in the OR and rush those organs to the hospital where the patient who needs it.
Okay, so they would be pronounced dead in the OR.
That's right.
Oh, I see.
Yeah. The family, in the organ donation situation, the family says their goodbye to the patient, and they go to OR and then remove. And then they receive the patient back without just those organs that were taken. And we'll talk about how that doesn't affect the funeral viewing, embalming, or anything like that. And the family would not know, I mean, the family consents to all that. They know what's going on. They're aware of that.
The reason I say this, because I donated my mother's corneas,
Mhm.
because she was too old to have anything else
Yes.
donated. When I went to see, after her death, when I went to
Mhm.
see her actually in the, well, actually it was in the ER, they had this thing on her arms, okay? But she was dead.
Yeah. Now, let's talk about certain things that can be removed. I don't think I have that slide anymore. It was a little too gruesome for some people, so I didn't explain it, but let me explain it. There's some tissues of the body that we can take even after death. Corneas, skin, and bones. Okay? They can remove those even at the funeral home. And I don't know why the eye has such elasticity that it can be used after death, but it can. But the skin can be used for burn victims, and bones can be used transplant even after death. But these, a patient is kept on life support. None of these are removed except the patient is going to die, but right before that, okay? Right at that time of death. Because if the patient is in the funeral home and we take these, they're not any good. Understand? They have to be gotten to the patient quickly, to the recipient. Okay? So here are the organ donation of organs, or heart, kidney, liver, lungs, pancreas, small intestine. Here are the tissue: cornea, skin, heart valves, bone, ligaments, veins, and arteries. Those are considered tissue. But any of those could help a patient live. Yes, sir.
Does age have a factor in the donations?
It does. Most heart procurement agencies say about 55 and older, they aren't donors, but you still may be on your driver's license as a donor. And I was still there because they usually say, well, what if you're 60 and there's another 60-year-old that needs your heart? Okay? So they say, let us make that determination. Don't refuse to be an organ donor because you're 56. But that's kind of like, and if you were to have some kind of a disease, cancer, MRSA, illness, something like that, you couldn't be a donor. So you can do it by way of your driver's license. You can do it by way of your advanced directive forms. And it used to be that family members had to be asked by the organ procurement agency, I know they're a donor, but is it okay if we take her heart? How about her spleen? Would that be all right? They had to go down the list. And I had to sit there with them going, this is awful.
Yeah.
Well, they changed it. Now they go, if they said they were a donor right here, then they're a donor, and we don't have to ask anymore. In fact, the family shouldn't be able to deny it. Now let's say I never put it on my driver's license, I never put it on my advance directive, and I'm dying, and my family goes, I think we would like to donate Larry's organ to science. He didn't say no. So I think that would be a good thing. So they can offer that, but they can't deny it when the patient said, I want to be an organ donor. So these organ tissue procurement agencies must be called every time there's a death. So every time there's a death in this hospital, the nurse will call. Do you know your local organ procurement agency's name? Anyhow, you've got one in your area. I think yours is LifeLink. I think yours is the same one that we use. It's out of Tampa, so it must be the closest thing. So that agency gets on the phone with the nurse. This patient has died, and they go, okay, are there any diseases prevented from being a cornea donor or skin and bone donor? No, and so then they might take care of that at the hospital or at the funeral. So then, if there's some tissue that can be used they need live organs, they need good organs from a beating heart, then they would review that with the nurse. And then they would actually come in here and see the patient and review the chart and look at all those things. And sometimes that's just in a matter of a couple of hours, if not a whole day. So it's not belaboring when the family would like to take them off life support. And we'll talk about that tactical timing in a moment, but it's usually done quite smoothly. Yes?
Do you need a different permit to donate your body to like a medical?
Yeah, we'll talk about that. Yeah. It's a different kind of form, different kind of an agency that does it. It may be coming up soon. Nope. I wanted to get a smile transplant. They said that wasn't possible, but maybe I'll get one day. A living organ donation. I am a living person and I want to donate a kidney. I can't give both, but I can give one and I can still live. Okay? I can give a portion of my liver, portion of my lung, portion of my pancreas, and I still live. So I can be a donor that way. Okay? And that's more of a discussion while I'm alive. Someone needs something, have the same blood type, tissue type.
You gotta be healthy though.
Got to be healthy.
Yeah.
Yeah. And I might have to be on a certain medication or something like that and sustain that just for my own good. Here is the whole body donation you were talking about. If you want to donate your body to science so that they can use your body to learn on, maybe even have your skeleton cadaver hanging in some medical room somewhere with your, I know they want to have your name on it, but if you wanted to help science out, and for some people they go, well, I can get free embalming, free cremation with that. So I don't have to pay for the funeral. I mean, so it may be something you go, well, that way I wouldn't have to pay for the cremation, and they can learn something through it. For some people, they just love the idea, and others, they don't. So each his own. So that's possible. Yeah.
My husband works in an industry where he does take staffers.
Yeah.
And, you know, he does for knees, shoulders,
Yeah.
feet, ankles.
Mm-hmm.
And shot a picture was all the feet, people even really had nail polish on their toes. I mean, I guess you have to have, it's
Yeah.
gruesome, but yeah, you just have to have.
People in the medical field do have a sixth sense of humor.
You know, he just works with everything.
Yeah. If you work around here long enough, you'll get a sixth sense of humor.
Yes, and he does have a sixth. He's coming to me now.
Yeah. Yes.
My husband donated his body,
cost more to do that than to cremate.
Really? Well, these agencies that
You
do
had
this
to
do it
pay?
for free.
They take it for
You
nothing.
get paid.
They-
More than just cremation.
If you go online and go into a whole body donation, you'll find that agencies do it for free.
Well, you know what could be, wow, you have
Yeah.
they have to go through a lot of testing, because even though my husband's working
Yeah.
on these cadavers, they can't have any disease. They
Right.
can't-
That's
so
right.
maybe
Yeah.
all that testing to make sure
Yeah.
that it's clean,
Mhm.
you know, because they can't work on it.
Or maybe they want to learn something by the disease you have.
Excuse me?
Maybe they know you have a disease and want to learn something from that disease.
Yeah, so maybe that's why.
Yeah, so they're different reasons.
I just brought up another question. I wonder if people, if you choose to have your organs donated, what expense is that to you to donate them?
Nothing. You don't,
Family's expense.
No.
not mine, but,
and the recipient
it's
maybe
not
has
like
an
they're not gonna
expense.
charge you to go in and take those organs.
Yeah, but I as a giver donating, there's no expense to me or my family as a giver. But there might be an expense to the recipient, the patient receiving that, as they would going in any hospital getting a procedure. Okay?
At the University of Michigan, where I got my degree, they paid $125 if somebody wanted to donate their whole body
Yeah.
to the, yeah, that's,
Okay.
I don't know if that's still true.
I don't know all those particulars.
Michigan, Michigan.
Yeah.
Well, it's
Yeah.
kind of too late now, isn't it?
Yeah.
But he told her.
Remember we talked about the definition of brain death was brain stem and brain, no activity, proven by 2 EEGs. So we're beyond that nowadays. We don't have to have that for organ donation, tissue and organ donation. Now we're going to work with the cardiac death definition, where the heart is beating at the time of testing, being sure that they're a good donator, but at the time of death, that they would have died anyway, then that we remove the organs. I hope that's very clear. We're not removing organs from patients that weren't going to die anyway. Okay? So don't get scared. Now you might be in the ER someday and think, oh, I'm an organ donor and I've got a broken leg and I wonder if they're going to take my heart. No. Don't worry about it. You're safe. You might hear at some funerals that a school teacher in Texas received a heart or lung or kidney, and then a little boy in Georgia received something like that. You will not hear the patient's name. That's a breaking of a HIPAA rule, but you might hear where they lived and that they were an engineer or a school teacher or something like that. Sometimes that's very helpful at funerals to know, yeah, mom's always been a giver, and you know, here someone else was helped. And I hear very good outcomes from that, of those kind of. I tried to donate my brain to science, but Dr. House said it wasn't worth anything. Keep looking. I gotta have fun with this, folks. It could be very boring. Remember I had said how the advanced directive state laws change. As far as the organ donation laws, they're pretty much the same. They're all on this kind of orchestrated about the brain death and cardiac death, and 2 physicians need to sign, and everything needs to be in order. So there's a lot more scrutiny over that. The main thing, these organ procurement agencies don't want to hit the front page of the paper as if they're taking organs, okay? So that's why they were so strict. They kept themselves out of litigation by keeping squeaky clean, and just Joint Commission said, well, you're too squeaky clean. You're too many rules. So this lessens some of that. The family, now let's talk about ministry. We've talked a lot about technology today. It's almost, are we really in a chaplain seminar? But again, I want you to feel comfortable in this setting. If you're a local minister, if you're a church leader, normally you wouldn't have this education, but you're coming in here to help, and I want you to feel comfortable in this turf, what's going on. Now let's shift. Let's talk about the ministry to the family. You're going to be working with them, and we're going to give the scenario here that we have planned, for whatever reason, organ donation or not, we planned at 4 p.m. today, we're going to take this patient off life support. Again, what did we have in order? We had in order that they were definitely in stage, at least, if not persistent vegetative state, if not brain dead. Okay? Again, brain dead or cardiac is only, we're talking about organ donation. But to remove life support, they have to at least need to be in stage. Now, there could be a patient who's terminal, who says, I'm tired of all this. Well, sir, you know if we're going to take off this ventilator, you're going to die. I know. And they may say that in writing, or they may say eye blinks, hand squeezes, or they may not be even on a ventilator and explain that. And so we take them off life support because that's what they want. They might be curious, well, are they depressed? We need to treat them for depression first or no? So all that may be an ethical issue, though. They're in their right mind to make this determination because they're going to die. But so they would review that these things are in order. Terminal for some, end-stage, persistent vegetative state, or brain dead. And then 2 physicians have stated that this patient can't recover, and the surrogates are ready. So there are times when these aren't working together. What if I have one physician ready to let go but not 2? Well, then we're not going to take off life support. What if we had 2 physicians ready to let go but the family wasn't ready? The surrogate was not ready to sign, even though the living will said that, but we need a surrogate signature. No, not now. So here's one of the big ways that chaplains can be there for families to help them during this time of grief. What I explain to our CEOs and CFOs of the hospitals who take care of the money, this moment right here is where the volunteer chaplains, and especially staff chaplains, can save them so much money that it will pay for the chaplain's salary. Remember I told you how hospitals get paid in the last seminar? I said they get paid by DRGs, diagnosis-related groups. Yep. And usually in this time, the diagnosis-related group, the DRG days are all spent. The hospital's eating the bill. Thousands of dollars a day it costs for ICU and that kind of nurse and that kind of machine and that kind of test. You know? So the hospital isn't getting paid all those days. So if the chaplain comes in and helps the family with that need, not pushing ending life support, but listening. And the family says, okay, I think I'm ready tomorrow. You've answered my question about the guilt, or what does God think about this, or is it the right thing to do, or who is this for me of taking them off life support? Here's one scenario, one kind of a explanation I use with ending life support. I use their words. You talked about pulling the plug. I can't pull the plug. That's like playing God. I go, you know what? We've been playing God. You all this technology? If we didn't use this technology, God would have had them up there, right? So we've been playing God. So why don't we stop playing God? Oh. So pulling the plug doesn't kill them. They would have died anyway without technology. That's how they're here, technology. So we're simply choosing not to use technology. Oh. So that wouldn't be bad of me to do that. I don't know. What do you think? I would not. No, you're not being bad. He's like, what do you think? You're listening. You're helping them with that. So if we take them off life support tomorrow instead of 7 days from now, is that saving money?
Mm-hmm.
If we help a family through their grief so that they're not wondering for the next 30 years, did I do the right thing by my mom? Did we do good? So we're not forcing or encouraging removing life support today or tomorrow, this day or next day, but it's listening. And through that listening, they go, I'm really not ready, but I think it's the right thing to do. I think I need to do that. And I simply go back sometime to the advance directive. What did George tell us to do? That's all we're doing. That's what he told you to do. Isn't that what he meant? Yeah. So you're not doing anything he didn't ask you to do. I know, I just love George. I can't do without him. I know, but that's what he wanted. So you're helping them see that timing. This is a precious moment. When I talk about holy moments, you have saved them from grief and saved them from agony and saved them from rethinking this for years by just sitting there and listening, answering for those questions. So in that moment, you're helping them work through some of those compassions, sitting down, not rushing. Let's say that the doctors have all signed, the surrogates signed, everybody's got everything in order so that we could remove the life support at 4 o'clock. Yet, we hear that there's a son that's flying from California and his plane got delayed and he's not going to get here till 6 p.m. So what do? We wait. Just because we have the signatures doesn't mean, okay, we got the signatures, got to pull it off. No, tact and timing. So we need the paperwork before we can remove life support. Yeah, we need the paperwork. But after we get the paperwork, doesn't mean we got to do it right now. Catch that? So let's say you as a chaplain hear something about the tact and timing where it's not the right timing. The pastor was going to come in to say the last prayer is not here yet. No. Okay, we can wait. Or I hear that the wife's out in the waiting room and she just can't pull herself together. Can we give her another 30 minutes? Sure. See, there's a moment where we have to have certain paperwork in order before we can start. But there's moments after that we can say, okay, not now. We can wait. We can give it a little time. Then there may be some things of the family emotional needs, different style of grieving. I don't think I put it there, put it up. Elizabeth Kubler-Ross showed us different styles of grieving. And so what you're going to see as a volunteer chaplain dealing with family is maybe they grieve different than you. And even in this grieving chart that she has, it's got to be on there somewhere. Let me find it. I'm probably getting ahead of myself. There it is. On this chart of grieving, there's denial, anger, bargaining, depression, acceptance. As the volunteer chaplain during this removal of life support, or even the death in the ER, what are you going to see the most of? Denial. I can't believe it. He was on the roof yesterday, fixing the roof, and now he's dead today. You know? Or this is 2 days before his birthday. Why not? Well, why not to after Christmas? And then when they do after Christmas, why not to after his birthday? But so it's like, they're different groups. Why? I don't understand. And this anger, you might see the son ready to punch somebody.
That lady.
You might see somebody else quiet in the corner. Remember, anger and depression are both anger, but anger, usually the outrage type is usually, I'm mad at somebody else. Depression is usually, I'm mad at me. And I sometimes go by the person who looks like they're mad at me and go, what are you thinking? I should have got him to the doctor sooner. Don't go there, honey. Don't go. It's not going to help at all. Or, you know, everybody tried to tell him to eat right or quit smoking and quit drinking. You did tell him, didn't you? Did you listen? No. And then they go, I'm so mad at him. I go, well, that's okay. So it kind of shifts in different kinds of anger, different kind of venting. The hospital should have caught this. He just went to the doctor 3 months ago and they should have caught that on that CAT scan, and here it is now. Fast-growing cancer. Or with babies, I've seen babies dying from drowning, and they're like, why didn't you see them? Why didn't you watch them? And I go, you know what was wrong here? Babies and water don't mix. That's all we need to be mad at, water. Because who opened the sliding glass door or who wasn't watching them, not the main issue. Do you know how much power you have in helping them through these holy moments? Their pastor may not be there. Their mother may not be there. Their brother may not be there. But you're there and you're seeing this happen and you go, you know what, I need to say something. Something I need to say. And again, you're not counseling. You're not dictating, but you're going, you know, I need to say something that will alleviate pain, alleviate suffering. There was one man in my county, he was a drag racer. His wife had begged him to quit drag racing. He was, honey, just one more. So they came to our town to do the drag racing in our town, and he had an accident. He had brain damage, and they took him off life support, and she was like, oh, I'm so mad at him. I begged him. I go, honey, did he do what he loved? Oh, he loved drag racing. Did you find him happiest when he, yeah. And I go, then he died doing what he loved. And you weren't going to be able to take that away from him. And she goes, thank you. See, her priest was up north and couldn't say those words, or may not even known the dynamic, but I was there. And those little words saved her from years of anguish. And I could have go, oh, who am I? I don't really know if I need to say anything. You know, it's holy moments where just a few little words help them alleviate a lot of grief. You were there for that moment. Let's go back to that because I missed a few things. There may be some medical errors or misdiagnosis. Whether it was real or not, whether it was really missed or not, you're going to hear about that, oh, I can't believe the doctor missed that, the hospital did this, whatever. Don't defend the hospital. Don't defend the nurses. Don't defend that. Just listen. And just be there to listen. And you might say, if you would like to talk to someone about, would you like to talk with the nurse or the doctor about this? Oh, no, we're fine. Well, then don't report it. But if like, yeah, I'd love to talk to administration. You have a risk manager here that does that. You have a patient advocate that does that. You have an ethics committee that does that. There are avenues, and I've sat down with many families with the risk manager, going to the charge and go, look, see this. I've even said as a chaplain, I want you to get the smartest doctor you know. You know smart? Yeah, he's our brother-in-law. I want you to get him. I want you to look at these charts. Why are you telling me that? Because you will never let this go until somebody looks at this. You got a smart attorney? I want you to get the smartest attorney you know. Have them look at it. You can get the medical records. When this patient's discharged, you can get the medical records. They can look through the whole thing. They go, well, you're asking? Yeah. Go check it out. Because I see people 40 years later going, I know they missed something. And even I, as a novice, not a medical person, going, no. But they've got this assumption. And they go tell 50 people, oh, they should have seen this and should have seen. They saved my uncle when he had this and they didn't save my mom. I can't. It's like, go check it out. Get some answers. So in that way, you may be there and go, would you like some information on this? I can get somebody from administration to help you with that. Would you like someone? If they do, then you can make a connection. Next is there may be some ethical issues, as we talked about before, this miscommunication, sitting and listening, offering the ethics committee. A family may be questioning why God, why now, questions about eternity, miracles. You know, we prayed one simple prayer, my mom was healed of that, why not my brother? I don't understand. She was older, he was younger, can't figure it out. I can't figure out God either. And I don't try to. I don't try to speak for God. I don't try to give my great little theological answers, but I listen and help them through that, help them just to mourn. Questions of eternity. I don't know if Dad knew the Lord or not. I don't either, but maybe he made a decision in his last moments. Even when he was in a coma, I wonder if his spirit spoke with God's spirit. I don't know. We might never know, but we have to let that go. There's just times when we can just be there to listen, be there to pray with them. And then having a last prayer before they remove life support. It's a time when you're all kind of hovering and they know it's going to happen at 4 p.m. and you may go, okay, we're going to have a prayer now. And there are certain timings when, it's one thing that nurses never say emphatically of when they're going to die. Remember I said life support and life sustaining? That it may be helping them live, but it may not be. They might die soon without it, but they're not going to die immediately without it. So that when they take a patient off life support, they might still be here minutes, hours, or days. And the family's going, I thought they were on life support. That's what we call it. Heroics, life sustaining. So it might not happen. So when they ask her, how long is this going to take? We're not really sure. We think maybe a few minutes. But then they're wrong. They've had patients that were on the breathing machine, on the ventilator, and respiratory therapists do this testing they call weaning. Let's say the machine is breathing for them 12 beats, and the patient is not breathing at all. And sometimes the patient can breathe 4 beats, and the machine breathing 8 beats. So it's assisting. So let's say the machine is breathing total for them, and they turn down the machine and see if they would take a breath, and they don't. And then later in the day, they turn down the machine and they don't. And they don't take a breath all through the day. But when you remove life support, they go, I can't figure it out. You know? Or the patient was breathing on their own mostly. The machine was assisting them. All this stuff was assisting them. They go, well, this may take a while. And they breathe one more breath and they're gone. Can you figure out God, the will to live, and the love around the family? I've seen so many family members, here it is days into taking off life support, and the patient's still there, and they're stroking the head, and they're singing songs, and they're telling stories, and they're going, we can't believe it, they're still here. I go, would you leave with this kind of love? It's the best thing they've gotten ever in their whole life. Would you leave? I would leave. And I go, I'm not telling you not to stroke and love and tease and tell stories. No. But that's probably why they're usually here. And have you given them permission to go? That it's okay, we love you and we'll get along? Have you also considered that maybe they want to die alone? That some patients are private that way? And that days after days of staying and hovering in the room and sleeping there at night, they finally, one stays in the room and the rest go to the cafeteria, and while they're gone, the patient dies. And they come back, oh, I wanted to be there. No, realize they wanted to be alone. Really? Maybe. They just wanted to die alone, you know? So we can't figure out death and timing. So when they're asked, when is it going to happen? I don't know for sure when it's going to happen. Maybe in 5 minutes, maybe in 5 hours, maybe in 5 days, I don't know. But they may give some kind of, hospice nurses are pretty good at noting this. They kind of have a tact for it, but they're not right every time. And so we have a way to kind of help them through that moment. We've had the last prayer in this scenario. We know it's about 4 o'clock when we're going to remove life support. We've had our prayer. And then the nurse may give some pain medication, something like Ativan or something to calm the patient down. Probably the same kind of stuff you get before you go to surgery, just calms you down. They may give this because many times the family members are like, oh, she looks like she's gasping for breath, and I don't want to watch her gasping for breath. I can't stand to see that. So they may give something just to calm the body down. It doesn't take their life sooner. It just calms the body down. It would never be too much. That would be euthanasia. That's illegal in our county. So it may be something just to calm them down. Then they remove the ventilator and remove the IVs. If they're going to continue hydration for some reason or nutrition, they might leave those IVs and take the other ones out. And then they remove so I teach chaplains, don't focus on the monitor. Here's the thing we do when we first see a monitor. Beep, 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 beep. But the family's doing it too. So we're just standing there with them, beep, 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 beep. And I go, whoa, patient. Talk to the patient. In fact, I even go to the nurse and I go, can we just turn the monitor off? And just come in and let us know when they've expired. Because all they're doing is watching the machine, you know. So they've got a monitor over at the nurse's station, so they monitor. But the one here at the bedside, it's like all they're doing is staring at the machine. And then they go, what's that one? That's for heart rate, and that's for respiration, and this is for pulse. And okay, we get to know the machine, and you're curious too. But don't focus on the machine. Focus on the patient. And get them to talk about the patient. What did they do? What was their career? What was the funniest moment? You know, what did they teach you? Focus on the patient, not the monitor. And then the family has a visitation there. They may even move the patient and the family to a private room. Remember, we're taking off life support in ICU. That's usually a very techie place. A lot of machines, maybe even glass windows, sometimes even curtain dividers and not real room. So they might take this patient, since they don't need ICU anymore, they don't need the high-tech nurses and the machines anymore. Take the patient to a private room where the families can sit around and be more comfortable, because it's going to take more than a couple of hours. So they might as well just move them to another room and let everybody be comfortable. Because normally ICU doesn't have chairs and everybody's standing and standing and standing and looking at the monitor. And then they get exhausted. Then we move some chairs in, then the nurse can't get in to see the monitor and stuff like that. So it might just be easier sometimes just to move to a different room. Some patients being removed from life support are placed on hospice because they might last a while. Hospice is not only good for the patient, but good for the family. So sometimes they're called in to help, and sometimes they're helped with pain management for the patient, or just taking care of some symptoms, not to sustain anything. And now we're going to go in and we're going to see the deceased. This is a mannequin. I can't legally show you a deceased patient. This is a mannequin and family standing around. So this is a picture of us going in to help him. Okay, the scenario is the patient has expired. We're in a private room now. The family's coming in to say their goodbyes. And probably the people that have been around town the most, they've already said their goodbyes. But a few of those that have just come into town, they're not really ready for this, and they're saying more goodbyes. I like to give all family members that moment. Have you been in the room privately to talk with him or her? Have you had your time alone? No, I haven't. I would love that. Another say, no, I don't need it. Okay. What would you? And I start with the eldest and the spouse. Have you had your time? Oh yeah, I've had my time. Have you had your time? And they deny it or want it. Sometimes that can be the most, again, precious moments where they're just in alone and say whatever things, their apologies and whatever way, just to let go. And that eliminates the grief for years. Just, oh, I'm so glad I got to do that. So then, make sure the patient's covered. Sometimes the nurses do the best they can, but sometimes the ladies aren't covered or the men aren't covered. Just be sure the blankets are appropriate and everything. And usually the family members are too, but you may be the first one in the room going, okay, you need to take care of that. And sometimes calling a nurse into that. Ask the nurse to deal with secretions. Sometimes when they take the tube out, it starts to ooze or bleed, okay, because it does a little tear with the thin parts of our throat. Sometimes with the nasogastler or some other PICC lines or IVs, those start to ooze. Call a nurse in to deal with that. If I'm not asking you to do this, but if you feel comfortable putting a glove over your hand and taking a material like the bed sheet or something and putting direct pressure on that, and nobody has a clue what you're doing. Instead of going, nurse, 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 you know. But if you don't feel comfortable, you don't feel comfortable. You call the nurse, but you do it tactfully. But the family might see some oozing. You might see something. I know you're not medical people. I know you're not used to that, so it's simply, you know, call somebody to do that. But if you want to do something tactfully, you can. You can call the nurse to, well, let me tell you about the intubation tube, especially for victims coming in the ER and dying. When they're intubated there on the scene and then they die, sometimes a medical examiner does not allow that intubation tube to be removed until the medical examiner has released the patient. Because the very inserting of that tube out in the field, EMS, or in the hospital could have caused deaths. Could have. So they're, no, I need to check to be sure that wasn't the cause of death. And then when they're assured, then that tube can come out. So when you walk in the room like in an ER and the tube's still there and the patient has died and you're helping the family and they go, why is this tube here? Let me go ask the nurse to see what's going on. And you go, are we going to be able to remove the tube? No, the medical examiner hasn't released the body yet. Or they just have, but we haven't got time to get in there to take it out. So once that gets okay, I take the family out of the room, they take the tube out appropriately because you don't want to see the mucus and stuff. They take that out appropriately, family comes back in and sees the patient. So that way, you kind of up on how the system works with the tube, the medical examiner, so you're not like, oh, I didn't know that. So you're kind of aware how things work in the ER and ICU. What if the patient's eyes are opening, just like in the Western show, you know, they put coins over their eyes? Same thing, you just need a little bit of weight sometime to hold the lids down. That can be very tactfully done with a glove and putting just a little bit of pressure on the eyelids for about a minute, and normally they stay down. Sometimes they creep back open, you have to do it again. If you don't feel comfortable doing that, you don't have to. But if you do, you can put a glove on and do that. Oh, I missed the top one, very important one. Standard, follow standard precautions. If this patient had MRSA before, or VRE, or staph, or anything else, they still have it. But here's what families do. They were wearing the mask, they were wearing the gloves, and when they die, they take the mask off, start kissing him. And I go, honey, he still has MRSA, or whatever. We need to keep protecting ourselves. You don't want to get that, because the nurse may not be there to stop that, okay? So understand, even at funeral homes, the funeral directors get trained in all of this stuff, standard precaution, because they still have it. So understand, you need to be appropriate when you're touching the patient and there with the family and help them to do that too. Closing the jaw is not that simple. If they've just been intubated at the ER and they've died and then they take out the intubation tube, sometimes that's quite simple. But if they've been intubated for quite a while and the jaw has been open, or it's been left open and then they've died and then they remove it, rigor mortis may have set in, to try to get this jaw to close might not be simple. You might sometimes put a pillow behind the head or a rolled up cloth under the jaw, but sometimes it just can't be helped. And the wife is there, honey, close your mouth, close your mouth. You know, it's like, well, we can't help that. So they don't want to put restraints on it or anything that looks awkward. So just realize that can be something that they'll just have to deal with to leave open. And then in an ER death or an ICU death, there's sometimes patient belongings that are there. That's the hardest thing for a family to do, to take that bag of the wallet and the watch and the keys, shoes, glasses, whatever, and I'm taking this bag home and they're not going with me. So I, as a chaplain, go, let me put this in the car for you. Walk them out. It's here in the trunk. Remember, you're going to forget where this is. It's here in the trunk. His ring's there. His watch there. His wallet's there. Or it's here in the back seat. Because they'll, you know, they're totally under stress and they'll forget where it is. And you put it there. And all that stuff is signed out by the family. We took this ring, we took this gold, we took all this. So that it's not still at the hospital, okay? It's all signed out that that was taken, because they get confused where it is. So all that's signed out so they can know where that is later. Sitting with the family. We've talked about the denial and all. Then we may just ask, tell me about him. Tell me about George. What did he do? What was his career? Nurses comment on this with me. You're in the ICU and you're talking to families, talking to patients, and laughter breaks out with us in the room. And they go, what were you laughing at? I go, we found something. I didn't tell a joke. No, there's no time for jokes. But they saw something, or I saw something, and it just alleviated the moment. And then we go back to passing around the tissue, and then something else is funny, and then we pass around the tissue. So there are certain times, again, holy moments of laughter, where they go, boy, did I need that. You know? And they just laugh at, oh, he used to wear his baseball cap and he doesn't have one on now. What if he's going to have one up in heaven? You know, just whatever. It's just something that helps them kind of release the moment. And what did he love doing? How did you meet together, spouse and all? And just sit and listen to bring peace. There's a whole seminar I'm going to bring for you on how to do funerals. And that's a whole science in itself. Now, I know you all may not be ordained, but as a volunteer chaplain, you may be working with the family and they don't have a minister. And they go, you know, I really like you. We spend a lot of time together. Can you do the funeral? I go, I never have. But can you? Can you say a few nice words? Can you read some scripture? Okay. Or you can go, no, thank you. You know, you can deny, refuse, and help them get a minister, another chaplain. But it might be something that you can do to help the family through that. You may be, and the first things out of their mouth is, I wonder what this is going to cost. I wonder what funeral home we're going to use. I wonder, all the kids need to fly back. Wonder if we need to have this on Thursday or Friday. And I go, let's just be here together. I know these things are important, and we need to work those through. And then they talk about, you know, how long does it take to embalm a body? How long does it take to cremate a body? And some of those things we'll talk about. So you can go, well, in our area, it's about this long. Or here's some Florida rules that, you know, they need to wait on certain things. So we'll talk about those later. About the viewing and different costs and different things and different funeral homes. Let me say this to make it very, very clear. Remember when we talked about solicitation and giving our opinion about things? Do not tell your favorite funeral home. Do not tell your favorite pharmacy. Do not tell the funeral home that your mom went to that they did such a terrible job on. That's solicitation. But always have a list of all the funeral homes in that city where they're going, or yellow pages available, and they may go, we need to make some calls right now. Here's a whole list. Don't put a check by one and skull and crossbones by the other. Just a list, okay? So it's no, I'd really go for this guy. But you might say, there's all kind of prices out there, call around. Because there is, you know. And so they may look into that and check to see what's a good deal. And then the funeral home will take care of death certificates. And your hospital may have a morgue here where they take the patient temporarily before they choose a funeral home. There's a whole science in how to deal with that too, of when to remove. And then different funerals for Islamic or Jewish who bury within 24 hours and don't embalm, wash the body. And they have their cultures that needs to be done things pretty prompt and quickly. So just to understand some of this. Did you know that funeral directors are so short-staffed that they work on a skeletal crew? I gotta have fun, folks. Okay, farewell and blessing. You're touching, you're making your decision, you're bidding the family bye and farewell. Do you want to call them or send a letter? That's up to you. I'm not saying you have to. You're volunteers. You've got so much time, got so much ability. But if you want, let's say if you wanted to send them a letter, here's what I would do before they die. I would, because the chart's going to be gone pretty quickly. Before they die, I would go to the chart and go to the family and go, would it be okay if I sent you a letter this week? Because it may not get out tomorrow. That would be fine. May I have your address, and I'd like to send you a little letter. And in that you might have all the staff. You're the nurse working with them. Will you sign? You're the respiratory therapist. You're the doctor. And everybody kind of gets together. Because you're not going to find those same people tomorrow. But you're thinking ahead. I've got these cards, and we buy them in the hospital. We have these little sympathy cards. And then everybody can sign. And all the nurses can say their goodbyes, farewell. So it's kind of a camaraderie working together. But I'm not saying you have to send a letter. I'm not saying you have to give a phone call, but I'm saying you might want to. Something you're thinking about. So now I've bored you to death. Any questions? Obviously, I didn't answer every scenario. I've tried to, and we will have a whole lot of other training coming years to come, and different things like ministry predicaments, technology and terminology, funerals, grief, self-care. Maybe to the day I die, I'll quit thinking of other things to teach you. But until then, we love it. Any questions? Yes, ma'am.
I have a general question.
Okay.
What do we do with the applications that we fill out? Do we have to take an application to each hospital?
Which hospitals are you thinking of?
I would like to do all three. In
Are
the
there-
county. Springfield,
Okay.
North Carolina.
That's just for our hospital of the health management hospitals?
Okay.
Are those like, you're talking about Spring Hill?
Spring Hill or Oak Hill?
Well, Oak Hill's not, go ahead.
Yeah, Oak Hill's not one of ours, but Spring Hill and Brooksville are ours in this area.
Okay, would I take the application to both hospitals? Get a
Yes,
copy of the
yes.
application?
And Dade City, if you're close to that one, that's one of ours too. But the other hospital, I'm not responsible for. I don't know what they want as paperwork.
That's why I asked the question.
Yeah. But those are good for those three hospitals in your area. And you've got the steps to become a volunteer chaplain to jump through. And Paul and I will get, if you're interested in leadership of this next meeting I'm going to have in a few weeks, get with Paul. And he's going to be contacting a few prominent people he's got on his mind. And we will get together and talk about a committee. And there will be an administrator who is assigned to this committee, will take things to administration for you to help solve we need a pager, we need a better office, or whatever, solve those kind of things. So you don't feel all alone. Let me pray a prayer blessing with you as we send you out today. And just ask the Lord's presence. Thank you, Father, for being here today. We know that your heart grieves when your children pass, but it also rejoices when you receive them in heaven. And Father, we're just kind of, both emotions are hard to handle sometimes. This rejoicing for them and hurting for the family and us. And we thank you that we can be there during those holy moments. Thank you for what we've learned today. Thank you for this great group and what they're going to accomplish. I pray your blessing upon them, for all these physicians and nurses and respiratory therapists, all the staff, and these chaplains today. As they touch patients, I pray that they will find healing, find comfort, find hope in their life. We ask for this in the name of our Lord Jesus Christ. Thanks for being here.